Ischemic heart disease is due to occlusion of the coronary arteries, may be partial or complete. The result of ischemia or less blood circulation or no blood circulation, the effect on myocardium is presented in ECG in three ways: myocardial ischemia, subendocardial myocardial infarction, that is non-Q wave infarction, or transmural myocardial infarction, that is Q wave infarction. The sequence of events in transmural myocardial infarction, in the earliest change is elevation, ST elevation in the corresponding leads. Many hours to few days after, there will be appearance of Q waves, pathological Q wave, and the T wave inversion. Days to weeks after, the Q or QS complex will persist. The T wave inversion symmetrically deep and inverted, and the ST elevation will regress. Months to years after, the Q and QS will persist, while T wave will gradually return to normal. The location of the infarct and the typical location of the infarct can be seen in the particular leads. For example, in anterior infarction, the changes will be seen in 1 AVL V1 to 3, while in anteroseptal V1 AVL V2 V4, anterolateral in 1 AVL V4 to 6, high anterolateral 1 and AVL, inferior in 2 3 AVF, and inferolateral in 2 3 AVF and V5 6, while true posterior infarction is in V1 and V2, and right ventricular infarct in V4 to V4 to V6. The posterior infarction, true posterior infarction, subendocardial infarction, and right ventricular infarction needs separate discussion. In true posterior infarction, mirror image of the usual changes, that is tall R waves, ST segment depression, and upright T waves in leads 1, 2 and 1 V2. Subaqueous endocardial infarction, persistent ST depression and T wave insertion in several leads. Right ventricular infarction, ST elevation more than 1 millimeter from V4 to V6 in the presence of inferior infarction. This is subendocardial myocardial infarction. Subendocardial, here part of the cardiac wall is involved. This is transmural myocardial infarction, where the whole width of the myocardium is involved. Typical early myocardial changes, myocardial infarction changes. This is in right precardial leads, and this is in left precardial leads, limb leads and left precardial leads. Typical QS pattern and ST elevation in right precardial leads, appearance of pathological Q wave and ST elevation in limb leads and left precardial leads. Typical anterior infarction, ST elevation V1 to V6, V5, V6, anterior infarction. While lower down, it is anteroseptal myocardial infarction. QS pattern is seen from 1 to V4, anteroseptal infarction. Again, this is anterior infarction where the QS pattern is seen from V1 to V6, and downwards, this is inferior infarction. ST elevation in 2, 3, and ABF is seen. Again, inferior infarction, typical ST elevation in 2, 3, and ABF, and reciprocal changes in the anterior leads. Reciprocal means ST depression, the reciprocal leads. Again, this is inferior infarction, ST elevation 3 and ABF and downwards. This is true posterior infarction. There are presence of R wave in 1 and 2 and ST depression. This is sign of true posterior infarction. Here it is true posterior infarction and anterolateral infarction. True posterior presence of R wave in 1 and 2 with ST depression, while QS complex are seen in 4, 5 and 6, that is posterior plus anterolateral infarction. In the second slide, it is anterior subendocardial infarction. ST depressions are seen in all the chest leads. ST depression, typical subendocardial infarction. Now coming to the conduction disturbances, the conduction disturbances can occur at the synovial node, level of synovial node, at the level of atrioventral node, or at the intraventricular conduction defects can occur. Now, the synovial node block and arrest needs separate discussion. Coming to the atrioventricular block, first degree atrial block is characterized by increased PR interval. In the ECG, the only main sign is PR interval is increased. It will be more than 0.2 seconds in duration. Second degree heart block can be Mobius 1 and Mobius 2. The Mobius zone, which is also known as Van Kimbeck's phenomena, in this block, the PR interval goes on increasing gradually till a complex is dropped. Till the complex is dropped. And this cycle is repeated again and again. In Mobius 2, normal PQR complexes, all of a sudden, we find that a P wave is not followed by the PQRS complex, QRS complex. In high degree advanced blocks, there will be atrioventricular block with constant at constant intervals, like block there can be 2 to 1 block, 3 to 1 or more, or there can be variable block number after no irregular block or regular block. Regular will be after 2 to 1, 3 to 1. That is after 2 wave 1 QRS complex comes. Here after 3, 1 QRS complex comes. Third degree heart block, it is complete blockage of the atrial impulses to the ventricle. The atria contract at their own level and the ventricles at their own level. Though there is no relation with the atria and the ventricles, the atrial rate is more than the ventricular rate. In this conduction defect, the PR interval will be variable and the RR complexes will be equal. Then we come to the intraventricular conduction disturbances. Right bundle branch block. Here, the there is tall and wide R in V1 and wide and deep S in V6, and the duration of the complex will be more than 0.12 seconds. Left bundle branch block, again the timing will be more than 0.12 seconds, and there will be deep and wide S in V1 and tall and wide R in V6. Left anterior hemiplug, that is the anterior branch of the left bundle is affected. In this, there will be left axis deviation and there will be small q in V1 and small r in V3. The timing of the QRS complex will be normal. Likewise, in posterior hemiplug, that is the posterior branch of the left bundle, the QRS complex will be normal in timing and there will be small r in V1 and small q in lead 3 and there will be right axis deviation. Bifascicular block, in bifascicular there is right bundle branch block plus one of the branches of the left bundle occurs. And bifascicular block, the pattern in ECG will be right bundle branch block pattern plus X deviation, either right or left. That will be bifascicular. In trifascicular, the bifascicular block plus increased PR interval. If the PR interval is increased more than 0.2 seconds, that will be trifascicular block. Now talking about the sinusoidal block, sinus node block is an occasional absence of one or more of the beats of the PRC complexes. The PP interval, including the SA block, are almost exact multiple of PP cycles of the basic rhythm. In sinus arrest, the SA block, the, the type of SA block, long PP intervals due to sinusoidal blocks are not multiple of the PP cycle of the basic rhythm. The PP interval preceding the longer pause becomes progressively short, shorter until a drop occurs. Right bundle branch block, there will tall R along with wide QRS complexes, and total QRS complex will be more than 0.12 seconds in timing. RSR pattern in right pericardial leads, particularly lead 1, broad and slant terminal S waves are seen in one AVL and left pericardial leads, particularly V5 and 6. Left bundle branch wide and tall R waves in V6, which may be M-shaped. The total QRS duration is more than 0.12 seconds or more. The QRS complex in one AVL V5 and 6 may be notched. The S wave in the right pericardial leads are often abnormally deep. Left anterior hemiblock, that is when the anterior branch of the left bundle branch is affected. Marked left axis deviation, a small q in 1 or a small r in lead 3, normal QRS duration. In left posterior hemiblock, the posterior branch of the left bundle is affected. Marked right axis deviation, a small r in lead 1, a small q lead 3, and normal QRS duration. In bifascicular block, along with the right bundle branch block, either the anterior branch of the left bundle branch is affected or the posterior branch of the left bundle is affected. The pattern on ECG will be that RBB with left axis deviation or RBB with right axis deviation. That will be bifascicular block. Trifascicular block, if we add into bifascicular PR interval, more abnormal PR interval, there is a PR interval more than 0.2 seconds, plus bifascicular block of number of this type or this type. If we add PR interval more than 0.2 seconds, that becomes trifascicular block. This is right bundle branch block is affected. Typical pattern in V1 and V6 are RSR pattern in V1 and wide QRS complex, while wide S in V6 and total duration is more than 0.12 seconds. This is a typical right bundle branch block RSR pattern in V1. Again, RSR pattern in V1. The duration is more than 0.12 seconds and deep S waves in V6. The left frontal branch block typical changes are wide S in V1 and wide R in R in V6. It may be many times it may be nosed, and the duration will be more than 0.12 seconds. Duration will be LBB, deep S wave, deep and wide S waves in V1 and V2. deep, wide R waves in V5 and V6 along with ST depression, left ventral branch block. The anterior branch of the left ventral branch is the QRS complex will be normal, but axis deviation will be left axis. There will be a left axis deviation or one up in one and S deep here in three. Left axis deviation with normal QRS complex, a small q in V1 and a small r in lead 3, a small q in lead 1 and a small r in lead 3, and left axis deviation. This is anterior vesicular block, left anterior vesicular block. Atrioventricular blocks, typically this is first degree heart block where the PR interval is increased. This is Mobitz 1 where the PR interval goes on increasing gradually till a P wave is not followed by a PR complex. This is Mobitz 1. Mobitz 2, normal QRL complexes are not followed. One of the P after the P is not followed by QRL complex. There are normal PQR complexes. Then all of a sudden a P is not followed by QRS complexes. In high degree AV block, there are different blocks 2 to 1, 3 to 1, or 4 to 1, and sometimes irregular blocks. This is after two P waves, QRS complex comes. Here is a regular 2 to 1 block, 2 to 1, 2 to 1 block. Again, this is 2 to 1 block. Here it is irregular variable. This is complete heart block where the atria and ventricles contract at their own. The RR interval is constant, but the PR interval is variable.